Now, the first part of the morning, we covered the medical history, the common medical situations, office protocol, airway management and prevention. And now we're going to cover the Ohio State Dental Board mandated topics. Now remember, there are excellent courses and books on the subject, and knowledge is powerful. It builds your confidence in these situations. So this is just a resource for you. I was asked, would I share my PowerPoint slides, and I'm making arrangements to do that. That's fine. But just know they're a starting point for your education, not the end, okay? All right. So the first topic we're going to cover is bleeding. Now, we're not talking about bleeding on probing. We're talking about bleeding that doesn't stop, okay? Bleeding that doesn't stop. And so we have to have a little background into how does bleeding normally stop. And so we have the injury to a blood vessel, and that releases clotting factors from the damaged cell itself, the vessel itself. It releases platelets, and we get a little plug. And then it begins the plasma cascade that ends with a fibrin clot. Now remember that this cascade leads to prothrombin going to thrombin, and the final process of that cascade is fibrinogen ending up with fibrin. Now, the best way to handle bleeding is to prevent it. So we're going to do a thorough history, and most people will be able to cite any history of abnormal bleeding, prolonged nosebleed, menorrhagia, prolonged bleeding after minor cuts, where their teeth bleed profusely during toothbrushing or flossing or trauma. But then we're going to do our intraoral exam and our physical exam of the patient the day they come in. We're going to look for petechiae, and remember that the petechiae are the very small intradermal mucosal hemorrhages, or purpura, areas of mucosal hemorrhage that are larger, or ecchymosis, frank bruises, or telangiectasias, dilated little vessels all over. Now, when we see these patients, and we see a lot of these in our geriatric population, and we ask our patients about their bruising, they'll say, oh, that happens. I take aspirin. That happens. I'm on Plavix. That happens. I'm on Coumadin. That happens. These are people that our ears need to go up. These are ASA3 patients, okay? They have capillary fragility. They have problems. And how we're going to treat those patients or what we're going to do is going to be dependent on the severity. So if somebody has a platelet disorder, a coagulation disorder, or a defect in the blood vessel itself, that's how we would treat it with first aid depending on the cause of it, right? Now remember, aspirin creates platelet disorders, right? It prevents the aggregation of platelets. That's why it works. So people taking routinely aspirin have a bleeding disorder. If they take an occasional aspirin, they do not, all right? So we already have moved somebody, if they take a daily aspirin, into an ASA2 status. So we can have a platelet quantitative disorder, meaning not enough number, a quantitative disorder. An inadequate production, as we see in leukemias or anemias or myeloplastic disorders. We can have cirrhosis. We can have dysfunction of the platelet, like in purpura or uremic syndrome, or we can have drug-induced destruction, and these are our most common: heparin. People having a hip replaced or knee replaced, placed on heparin so they don't clot. You can have a qualitative platelet dysfunction, an inadequate platelet function. It doesn't function well. You have enough platelets, but they just don't work well. And that's what we see when people take aspirin. The platelets don't aggregate together. Or any non-steroidal, like ibuprofen. Okay? Or if they have uremia from kidney disease, or multiple myeloma, or bone cancer, they may have enough platelets, but they may not be functioning well. Now, this little bleeding cascade reminds us of what's happening in the plasma. And there are two routes. We call one the intrinsic pathway and one the extrinsic pathway. And the end result of these pathways is that prothrombin goes to thrombin, and after thrombin's formed, it triggers fibrinogen to go to fibrin, and we have this great fibrin-formed clot, thick clot, okay? Now these cascades are little factors that start, and once one factor is formed, it triggers the next factor. But in any of those protein precursors, we could end up with a problem or an interference with them going to completion. And we call these coagulation disorders. So first we need the platelets, then we need the coagulation factors from the plasma. And if you have a problem with the platelets, that could keep you bleeding. If you have a problem with the coagulation, that could keep you bleeding. But how we treat it would be dependent upon where the problem is, okay, where the problem. So heredity. Now, if you have hemophilia, factor VIII deficiency, you usually know it. And the dentist is probably not going to put that patient with you in an unsupervised situation, okay? I'm not sure the dentist wants to see that patient in an unsupervised situation. Many of those patients are transfused, go to the hospital, and we do them in a hospital setting, okay, especially in an extraction case. So these are not ones we would see and not know or recognize. The patient knows this, okay? You can have coagulation disorders that are acquired, a vitamin K deficiency, liver disease. And a lot of people we ask about their drinking, is it social drinking or is it abusive drinking? You can get liver disease and end up with coagulation problems from abusive long-term drinking, okay? Or if the patient's taken warfarin or Coumadin, okay, that's another acquired coagulation. Or you can have hereditary diseases of the connective tissue itself, the capillary beds themselves. And we see these telangiectasias on the spider veins everywhere, okay? Or we can get acquired vascular disorders, most commonly vitamin C deficiency, capillary fragility. The capillaries don't respond well. Now, our past medical history should reveal systemic conditions associated with platelets or coagulation. You know, if you've had a severe infection, cancer, cirrhosis, HIV infections, pregnancies that you bled, systemic lupus, uremias. These are high-risk patients for bleeding. Prior excessive or unusual bleeding, family history of excessive bleeding may imply some kind of hereditary situation. But most commonly, the people we see routinely are the drug-induced bleeding potentials. Okay, warfarin, aspirin, nonsteroidals. And we sometimes cross right over those. You know, patients on Coumadin, patients on Plavix, patients on aspirin, and we run right through that like, okay, they're a great ASA1 patient, but they're not. Put that in our head that we can get into trouble here, okay? So we do our physical exams and we look for the general appearance. Are there signs that indicate hypovolemia? Do they have a heart rate that's too fast, tachycardia? Is their blood pressure too low, hypertension? Do they exhibit pallor or very bluish tinge to the mucous membranes? Do they have sweating, diaphoresis, or infection, which would be a problem? And so then we examine our mucous membranes for any petechia or purpura, signs of bleeding in the deeper tissue, any signs of bleeding in the head itself, confusion, neurologic things. That is more of a stroke in nature, and we'll talk about that when we talk about stroke. And then we ask about their screening tests that evaluate the components for hemostasis. So if someone were new to the practice, that particular patient may be screened by the general dentist, general supervising dentist, for any hereditary disorders by ordering a blood test. But more commonly for us, we have patients of record that are routinely getting their Coumadin levels checked. And so when we see them, they've been on Coumadin, we say, now, when was the last time your Coumadin level was checked? Oh, I'm due to have it checked tomorrow. Well, when did you last have it checked? 10 days ago. Well, it would be better if we saw them right after they had it checked, okay? But what was it? Has it been stable over the last 6 months? Yes. Have they made any adjustments in your coumadin level? No. Well, I feel more comfortable with that patient than somebody says, well, I've only been on it a couple of weeks. I'm not quite sure they're working it out. Maybe we're not so comfortable there, okay? So they measure the coumadin level by the INR, Internationalized Normalized Ratio. International Normalized Ratio, INR level. And that is a measure of the PT. Now, the PT examines the extrinsic and common pathway. The extrinsic, that's factor 5, 7, and 10, prothrombin and fibrinogen, and it is measured against a laboratory control. So if the normal control is 12 and the laboratory control is 13, they'll normalize that so it's all reported so as a standard number, 1.5, 2. These are normally someplace between 1.5 and 2 for normal coumadin fibrillation problems. Some of the deep venous thrombosis, their target range is 3. Now when it's 3, I'm not sure this is the patient you want to do a whole mouth root planing and scaling in one visit on. Maybe that's a person you want to do a little smaller area at a time where you can use your pressure anesthesia to help and you don't have problems all through the mouth. Now the partial thromboplastin time measures the intrinsic and common pathway. Now the intrinsic and common pathway, the typical range is 28 to 34. And what that says is if it meets those range, 30% of all the clotting factors are present. And usually that's enough to make us clot. How do we control it if it happens? What's the first aid measure? Well, number one, we're going to put direct pressure, okay? When I was in school, they used to tell us, put your finger in the dike. You know, literally take gauze, moisten it, wring it out, and press, and just hold. Press and hold. If it's, you know, I can't imagine in your situation, but if it would be profuse, you could use the facial artery, put pressure on the facial artery, find out where it is, put it on the floor of the mouth, but just slow down, pressure and hold. Now that'll give you time to think at least, you know, and that's what you need to do is just stop and think. Sometimes simple pressure will clot it. And other times you need a suture or you need staples or some kind of clip to hold it together. Now that, you're going to have to be calling someone in an emergency, EMS. You're not going to be doing that, okay? But simple pressure should clot it. Keep your sections that you're working in small on somebody that has a INR level that's above 2. And you want to do any blood or component replacement if you need it. Now, if it would be coming from an extremity, not only do you want to add your pressure, but elevate it. You know, keep it above the heart. You'll lose less blood. Okay, so if you were out in the field and you were trying to do that, elevated pressure, gauze, those are the kinds of things that will slow the bleeding down. And then remember that hypovolemia is going to happen. Okay, not enough blood. You're going to bleed out. Okay, so for immediate treatment, during to an undiagnosed coagulopathy, you don't know what's causing it. We've all watched those little emergency shows. What do they say? Give me some fresh frozen plasma, right? Because it's going to contain all of the clotting factors, and the patient will clot, and then we can find out what happened to the patient. For all of the patients we're seeing that were pre-screened by our supervising dentist, fresh frozen plasma should not be in our mix. A little bit of pressure, staying and working in one quadrant at a time. If we're doing scaling and root planing and the dentist is not physically present and INR level is up, above 2, we're probably better off to stay in one section at a time, not to do a full mouth scaling and root planing. Okay, everybody understands, limit the access and use pressure. Chemical techniques we can use epinephrine. Epinephrine is a vasoconstrictor, and it'll slow the bleeding down. We can use replacement vitamin K. That's going to take a while, okay? The liver's going to take about 10 days for vitamin K. Okay, protamine or desmopressin, those things that are proteins that will vasoconstrict. Collagen. You know, we have these little cellulose or gelatin sponges we put in extraction sites. You can place gauzes that have those factors right on the area that's bleeding. And so if you're working with a dental assistant, she's used to putting those into the extraction area. She can get you those and put those right in your wet gauze and press with that, and that'll help as well. Additionally, surgeons will use an electrocautery to burn the edges that are bleeding, or they'll use a hemostatic scalpel, and I had to look that up because I never heard of a hemostatic scalpel. And what that is electrocautery is a one-polar, you know, it goes from negative to positive or positive to negative. Well, hemostatic scalpel is bipolar and goes both ways. And so it'll sear that off without interfering with a pacemaker if somebody had a pacer. Okay, so that's what that is, or a laser works well. Now, the next mandated subject we're going to cover is the most frequently encountered thing we see in a dental office today, and it's called vasodepressor syncope. Okay? Now, it's 6 times more frequent than any other of the medical emergencies. Very, very frequent. Now, as we said, the demographic is changing, though, because vasodepressor syncope is common in, you know, our stoic males, you know, 16 to 45. But our demographics of who's coming to our practice with teeth are changing. So this may not be always for the future. Plus, dentistry has been so comfortable for people for so long now that there's less of a fear of going to the dentist. Now, common feigning is what it's called. I feel faint. But it's a sudden transient, meaning it's not long-lasting, transient loss of consciousness from lack of cerebral blood flow. Now, what is consciousness anyhow? In order for us to say we're conscious versus unconscious, we have to have 3 things happening. We have to be able to respond appropriately to a command or a sensory stimulation. So, Annie, are you okay? Right? Shake and shout. We've got the sensory, shake and shout, and we have the verbal. We have to have our protective reflux, meaning we can gag, we can choke, we can cough, we can get things out of our airway. That's a protective reflex, okay? And we have to be able to maintain our own airway. If we're groggy and we're not quite with it, and our tongue is lying in the back of our airway, you're not considered conscious, okay? You're not able to fulfill all 3 of those commands. What causes it? Well, you have the psychogenic causes, fright, stress, you're emotionally upset, you're in pain, or you have the sight of blood and you can't stand it, and you get weak knees, okay? And then you have the physical. If you stand for long periods of time, or you're really hungry or physically exhausted, you're in a hot, warm room and you're not able to move, or you're in poor physical condition, you would have vasodepressor syncope. Now, the patients are normally in this demographic somewhere between 16 and 45 years of age. This would be a psychogenic cause. You know, doesn't look very comfortable. He's sitting upright, and he's scared. You know, there's a bunch of people in a warm, hard environment. We would not anticipate that we would be surprised if this person became faint and ill, right? It doesn't look like it's a great situation going on. And then there's the physical. Now, if we stand upright for a very long time, the blood is all pooling in the legs. Not enough blood is going to the head, and pretty soon we're going to be hypoxic in the head. Now, actually, this is a test given by a cardiologist, and this table rotates, and they judge your receptors, your baroreceptors, and how they respond, and your heart rate and your blood pressure in different positions as they positionally move you to see whether or not you are more inclined to pass out in the shower or not, okay? So we have stages of vasodepressor syncope, and the first is called the pre-syncope stage. The second is called the syncope, and the final is called the post-syncopal stage. And in pre-syncope, what we have is stress, some type of stressing event, whether it was the sight of that blood, whether it was, I'm in pain and you're not believing me, whether it's, oh, I can't wait to get out of here, some kind of emotional distress that releases epinephrine from our adrenal medulla, a large amount of epinephrine. The large muscle groups are going to receive this epinephrine and through those beta-2 receptors do a massive vasodilation. The pupils will dilate, the heart rate will increase, and the blood pressure will go up a little bit. Now, what we're getting ready for is what we call the fight or flight, right? Typically, when epinephrine is released, if somebody comes up and scares me, whoo, get a rush of epinephrine. What will happen here is I will run, right? I'm going to run down the street. I'm afraid. I'm going to go get to my car. So all of my large muscle groups have to get a lot of oxygenated blood. So they're going to get the vasodilatation. My heart rate's going to need to increase because I'm going to pump it real quick to where I need. My eyes have got to dilate because I've got to run down the street and see what's going on. I don't need my near vision right now. Okay, so just think of it as fight or flight. And we want those things to happen with epinephrine. That's what it's for. However, if I'm sitting in a dental chair and that blood is all in my large muscle groups in my legs getting ready to run, and I'm still sitting there in your dental chair, I'm not feeling real good. I'm starting to feel nauseous, faint, warm. I'm not feeling good. And peripherally, if all the blood is in my large muscle groups, peripherally, I'm getting a vasoconstriction and I look ashen gray and white, right? I recognize this person. You don't look good. I mean, so the patient's still talking, they're still conscious, but they're telling you, I'm not well. I have a sense of unwellness. The patient's pupils are going to dilate, and the patient's going to tell you, I feel dizzy. I think I'm going to pass out. They'll tell you that. Their hands and feet are like ice cold. Their blood pressure's remaining relatively stable. It hasn't bottomed out, but their heart rate's higher than what it was before. You go to pick it up and feel their heart, and their pulse is like going real quick. And the consciousness in this pre-syncope stage is going to stay with them. They're still talking to you. And then it'll boom, it'll just be gone. So you'll fall over or you'll help them over. Okay, sit down. Okay? Now what happens here is when that epinephrine's released, the compensatory mechanisms start to fatigue. Like the heart rate's increasing, we're trying to keep the blood pressure going up to the head, but all of a sudden I'm worn out, I'm pooped, if you will. And so my heart rate's going to drop. And once the heart rate drops, there's not enough blood to the head and I'll lose consciousness. If I take the blood pressure right then, you might not even be able to record it. You may not even be able to record it. It may be like at 60 and you can't feel it because you have such a peripheral vasoconstriction, no blood being pumped. Now, if you place the patient into a supine or Trendelenburg position, gravity is going to take all of that blood out of those large muscle groups and it's going to return it to the system. Once it returns it to the system, you're going to get more oxygen back to the head and consciousness should return. Okay? Now, with the loss of consciousness, breathing becomes irregular or even apneic, and the tongue falls to the back of the throat. So our biggest thing here is going to be airway management, position the patient. Airway management, position the patient. Patient's going to look death-like. If it's not recognized, if somebody doesn't intercede, convulsions will ensue because hypoxia causes convulsions. So this can get very, very ugly just because it says for fainting. If you don't recognize and correct, you're going to have a patient that can get very sick. Okay? So the blood pressure bottoms out. We're going to position the patient in the Trendelenburg or the supine position. Once we do that, all of this blood that was down here in these hip muscles getting ready to run is going to return to the system. We're going to open the airway. Make sure we open the airway because if the tongue is flaccid back there, they won't be able to get the oxygen. This should totally reverse within 5 minutes. I'd say 2 to 5. I mean, as soon as you put them back, they should start to, they may still not be 100%, but in 2 to 5 minutes, they should be conscious again, where they say, oh, I still don't feel good. So you're going to administer your oxygen and your ammonial alveol, if they have very tight binding clothes at their, waistline, these skinny jeans, that's probably not a good thing because we're not going to get the gravity to give us the stuff back, so we're going to have to loosen that up a little bit, If they laid on the bed to get in, we might have to get them out, okay? Because we have to get the blood back to the head, okay? You're going to remove any of the triggers. Take the bloody gauze off their chest, okay? So if they've got a saliva and it's the clear saliva straw and it's filled with their blood, this looks dramatic to someone, okay? Take that away, get all that out of there so that they can start to recover. Now, this says if complete recovery does not recur in 15 minutes, activate the EMS. Now, Dr. Malamed, he's an anesthesiologist, and his level of comfort is a lot higher than my level. I would say to you, if this patient isn't starting to come on board in 5 minutes, I would be activating my EMS already. You do not know what other comorbidity factors they have going or that what other problems could happen. And so we want to make sure that we get the EMS on board, okay? Now remember, recovery should take place almost immediately if the patient falls on the ground or is placed into a supine position. If they fall, you got to watch you don't injure on something else, okay? So try to get them back into the chair. And if we kept them in this upright position, that's called a crucifixion. That's how we killed people, okay, in the Roman times. So it can lead to death. Some people think of feigning as being innocuous, and it can be if we correct it. If we don't correct it, we'll crucify the person. Okay, so recovery is going to be rapid, less than 5 minutes. I'd say 2 to 5. The pallor, nausea, sweating, and weakness, that's going to persist. And you might want to give them something sugary to eat, to correct the hypoglycemia. The blood pressure may take several hours before it comes right back to where they started, their norm for them. The heart rate and character are slowly going to kind of come back where the pulse is no longer steady, but it's back to normal, and the rate is there. But the tendency to faint again may be present for several hours. So whether or not you let this person drive home from the dental practice, you have to get your little algorithms. What does your supervising dentist want or expect from you, and what are you comfortable with? Remember, you have input too. You have a license. Now, very similar to vasodepressor syncope is a condition called orthostatic postural hypotension. Okay? Now, here we are, we're on a time schedule. We're all production mills today. And what happens is we get the patient examined and we're ready to go, and we hit the auto return and we start cleaning up our room and lift the chair and say to the patient, I want you to make your next appointment with the receptionist out here, and I've got to get my next one in, is basically what we're saying. Here's your hat, what's your hurry? Your teeth are cleaned and there's no cavities, great. And there's some good to that and some bad, like everything, there's pros and cons to everything, but this is a problem for people that are on medication, because if we are on beta blockers, when we go from posturally supine to an upright position, our body's going to take a little longer to recover and increase our heart rate. And so this failure of the baroreceptor reflex to increase the vascular resistance is going to make us feel dizzy for the same reason. We're hypoxic. That's why we pass out. But what causes it is what's different. And so that's why we have to know what we're dealing with. This one is usually pharmacologically induced. We're either on a vasodilator,